Like, what can we do to actually look at behavior change and creating space for you to take charge of your own recovery? And in terms of like burnout and just walking alongside somebody rather than having this weird power dynamic, I think it should be a core skill for every therapist to engage in, like just learning things like motivational interviewing and assessing readiness to change. Because I was that physio who would get, I'd ask like, how did you get on with your home program? And they're like, oh, sorry, yeah, no, I didn't get to it. And I'd be like, why not? And I would take that on. And it just kind of just changed how I thought about loads of things, but primarily about empowering people and educating them and motivating them to make the changes for themselves rather than, having to report back to teacher, here and fear that response. So I would say that every therapist should be a good coach.
Well done. You have finally discovered the most important health podcast you will ever need as a medical professional. The conversations you are about to hear are guaranteed to change your clinical practice and hopefully transform you into a better conversationalist. They could even make you better crack at parties. Welcome to Teacup, where swearing is guaranteed.
Oh, here we are. Michelle Lyons is jaw on chaw.
Oh, sun down of our on chaw.
Mine Colleen. That's probably where it finishes, isn't it? With our with the Irish Westmeath. Brilliant. Right, Michelle. What's interesting is I don't know if you remember this because we didn't say it before. But I met you actually in a therapy expo in 2023.
Oh yes, yeah. Feels like a million years ago, but yes, that was a good time.
You did you did a talk, and that was the reason. It was one of those ones where I came in. Very popular one. I'd stand at the back. I think I snuck in because I was speaking at it as well, so they let me in. And it was that kind of talk where I'm like, you go around talks. I don't know. I can't put my finger on it, but you tick you're not boring, which I think we need more people like that doing talks. So I was like, this was I was engaged. Like, content is good, obviously. That's not a problem. But I just went. Oh no! I need to say it to you afterwards. So I waited at the end. I said to you, that was really good. And then I also said in my head, I was like, I'm definitely gonna meet this person again in some sort of Star Wars out there kind of moment. I went, we'll have to chat with this lady again.
And here we are.
And here we are. So I manifested it, as they say.
Wow! Do you have lottery tickets as well?
No, I'm terrible at that. And obviously we've already had the pelvic punk on here.
Indeed.
You know what I mean?
My learned friend and colleague.
This is it. So we're going to get, I must get my 10 questions up. So we're going to get people who don't know who you are. Obviously, if they don't know who you are, they need to find out. So there's definitely loads of podcasts that you've been on. It wouldn't be hard to find who you are. So I'm just going to get straight into what I find important, which is 10 quick fires.
It's your show.
You ready to go?
Absolutely. Go for it.
Sligo or Fermanagh?
Oh, I would have to say I'm a very frequent flyer to Sligo.
Yes. The pelvic punk. Nil.
I know.
Andrew 1. Are you? Do you go to Sligo?
I do. I love Strand Hill and Ross's Point.
That's right. I'm from Strand Hill.
Oh, there you go. Shell's Cafe is a particular favourite in the Lyons household. So, yeah, it's a great spot.
Oh, nice. And you should go into the Manny Johnson's for a bit of cheeky ice cream. Bit
of Uachtar Rocha, absolutely.
It's Farlam Cockamillish, but we'll move on. Teaching or treating?
I love teaching.
I got that vibe off you.
Yeah.
Yeah,
it's good. Chats.
Yeah. It'd be similar. Coach or therapist?
Can you separate the two?
I like it. I accept it from you, Michelle, as it's supposed to be either or, but I don't think you can. I'm just interested in what people will, what have either the 13 guests, what people commonly say, because the go-to is therapist, isn't it? That's what we're trained to be.
It is, but I would say that sorry to interrupt the flow of your rapid fire, but when COVID was raging and everybody else was doing banana bread, I went back and I did a postgrad in health coaching.
Yeah.
And it absolutely just changed my brain, wrecked my head while I was doing it. But just kind of getting around that concept of instead of being the fixer or a mechanic coming in to fix people, like what can we do to actually look at behavior change and creating space for you to take charge of your own recovery? And in terms of like burnout and just walking alongside somebody rather than having this weird power dynamic, I think it should be a core skill for every therapist to engage in, like just learning things like motivational interviewing and assessing readiness to change. Because I was that physio who would get, I'd ask like, how did you get on with your home program? And they're like, oh, sorry, yeah, no, I didn't get to it. And I'd be like, why? Why not? And I would take that on. And it just kind of just changed how I thought about loads of things, but primarily about empowering people and educating them and motivating them to make the changes for themselves rather than, having to report back to teacher, here and fear that response. So I would say that every therapist should be a good coach.
100% agree with that, and everything you said about without. We'll probably come back to bits and pieces on that because, like most people who've come on here have said they're a coach more than a therapist. That's what they've gone with, coach. And I think exactly, and I think why I set up the podcast as well was to try and be a communication focus, because I think it's such a majority of what we do, and if we get it wrong, it kind of falls to shit. Because, really, without
very
that,
quickly, yeah,
really quick. And then some other really good people in this space talking about like. It makes it much easier. Weirdly, like it's hard, as you said. It wrecks your head. You have to get better at listening and asking better questions. But then once you've kind of done that in the first sense, it's much easier then.
Oh, it's liberating, but it's liberating for everybody in the equation.
Correct.
It's a win-win situation.
Absolutely right. Espresso or Americano?
I'm a double espresso girl.
Nice. Yale or Harvard?
Ooh, now you see, my husband is from Connecticut, and so we spent a lot of time down around New Haven. And I've spent a lot of money in the Yale bookshop over the years, so I'm going to go Yale.
Nice one. That was the connection. I was doing my research. Mary Robinson or Michael D. Higgins?
Come on.
That's a hard one.
That's very, very hard. You know what? I'm going to have to go with Manana Hare, and I have to go with Mary Robinson here because I think she did so much when she was president, but she's done so much since, and she's continuing to do it. Like she's fighting the good fight and getting the word out there, and she's tireless. But by a hair's breadth, can I just say, would I be able to pick one over the other? Because I love them both.
Nice answer. We're totally ripping the arse out of a quick fire, but I like it. Sun or snow?
Oh, snow. Easy.
Connecticut, I suppose.
Oh, anytime. No, I am not a summer child by any stretch. Like autumn and winter, that is my happy time. Big jackets, big fires, lots of good books, good red wine, stinky cheese. Happy me.
Happy days. Introvert or extrovert?
You see, I know I'm an introvert, but I can switch personalities. I can be the extrovert when I'm teaching or when I'm on stage, but then I have to refuel. My inner introverted fascist dictator demands it, so I have to refill my cup. So I like my alone time.
And that you see that quite a lot, and you see that with comedians as well. Interestingly, that kind of and when I did a recent coaching course as well, and you can't do enough of them, I don't think, in my opinion, but that's another thing. And we did a type coach analysis, which was, I don't know if you've ever done that. It was really good actually, and the way they did it and how you filled it out. If anyone's ever interested in doing something like that, it's not saying you are this or that, but they gave you different breakdowns, and everyone in the 20 of us in the cohort were placed in a different position on this, and it certainly didn't make, like, when you looked into the introverts, a lot of them were outspoken and did stuff. So it's not the traditional, they're quiet. Yeah. It's just that, like you said, sometimes require silence or away or, time to themselves,
Yeah, no. So what about you? Would you say you're an introvert or an extrovert?
I'm an extrovert.
Yeah.
Yeah. Oh, yeah.
You kind of feed off that energy, I would say, like not in a kind of vampire creepy way, but I would say that kind of fills your cup.
More people, the better.
Yeah.
Like the more I've I said 10 in my family, including my mum and dad. So it was like always busy. So I thrive off energy of people, and it sometimes has to be like I'll still be wrecked afterwards, but
Yeah.
I will be like, oh, I'll go back for more of that.
You get a good buzz out of that.
I'm just tired, but I'll come back. I'll be back in a minute. I need a drink. It just fuels it more. This one is p-value or listening.
Could we go with evidence-based listening?
Fuck off, Michelle.
Worth a try. I mean.
I love evidence-based listening. I think I had...
But, are you listening for the right things, know? Because
absolutely.
I think, we all love a bit of evidence-based practice, but also the biopsychosocial model as well. And sometimes the things that they say are important in the literature and the research might not be important to the person in front of you.
Yeah, I like
so
that. Yeah.
I would, if I had to choose, I'd go with listening.
Of course. Yeah. No, that's good. And I'm glad these questions are actually kind of slightly maybe more thoughtful than I normally do. So yeah, it is that one, isn't it? Because there is a way of listening. Like you said, if you get the coach, the thing is, if you haven't been coached to coach, you don't realize how crap we are at it. I think I said it way back in the second episode of this. I was talking to Ben Cormack and we were just saying, like once you realize that you're shit at it, it's light bulb. It is a bit annoying, but then you're like, oh my god.
It's horrendous. It's like going into the Marines, like where they have to break you down to build you back up again, and you just realize how uncomfortable you might be with silence and that need to fill the space or to demonstrate. My downfall was I would get very excited when I recognized a pattern in a patient. It's like, I know what this is, and I know what the evidence says, and I know how we're going to treat it, and it's great, and let's go. Instead of just being able to kind of just sit with them and as I said, and listen to what was important to them and what meaningful goals would actually look like. And it's being able to have that confidence just to kind of sit deep in the saddle and just stop talking.
Yeah. And it needs to be, because I think sometimes people throw it out like, listening, doing that, you should do this, you should do that. But we're even having something in our in-service training next week about reassurance. And there's a great paper by, it's only a recent one by Peter Sullivan's group. Yeah. And I can't remember, I don't know if you know the one, where they did the 5 interviews. Yeah. And they looked at what people were saying, and it was so interesting that they just kept going on about the MRI or the scan. The patient's going, I don't give a fuck about the MRI. And it was like, but I could imagine is sometimes you don't, when you read it back, you probably think, oh, right. But at the time, I wondered, the way, as you said, you're like, I figured it out. I know what I need to do here. And you actually have not listened to what they're saying. And I think that happens probably a lot more, and we're probably not conscious of it. And I don't think any therapist sits out to do that. Do you know what I mean?
No, I think, we all know that we're coming from a place of good intention. But again, it's to really make sure that we are keeping it very patient-centered and person-centered and not physio-centered. It's not about me knowing what to do. It's about what's meaningful for you. Yeah. And what are your goals, and then how can we reverse engineer them into bite-sized pieces that's not going to overwhelm you, but it's doable, that you're confident that we can do this together.
Yeah, cool. And then the last one, which is a bit of crack. You'll like this one because this isn't from me, although we now use this in my house. But
now I'm scared.
No, you don't be scared. It's just when a bloke's talking about menopausal stuff. He has to, I'm always a bit like, go easy here, Andrew. So, chicken peri peri or the change?
I'm listening to you. I'm just not understanding your goals here, Andrew.
It's a total piss take. It was just that one woman said to me, she came in, and this is what I want to explore with you now, questions. And I find kind of interesting. I think when it's not directly personal to me, I find this area and people going through this problem, which is real dynamic, real conflict for me. Because when you're not emotionally attached to somebody, you can be weirdly a little bit different in your empathy. Yeah. You know what I mean? You know the way it is. You can become less of a fixer. Yes. I think I lose my coach therapist fucking head when I have people close to me, and I end up being a muppet. You know what I mean?
No, I can't relate to that at all. What do you mean?
Yeah, exactly. Talking rubbish here. But yes. And people going through this, going through the perimenopause, crack me up because they've got absolutely my type of humor when it comes to darkness and straight up. And I like that. So I'm kind of interested. But obviously, if it's emotionally close to me, it's horrible, because it is really horrible thing. But one patient said to me, I said,
but it doesn't have to be. It doesn't have to be.
No, exactly.
I think that's the main thing, like, that I tried to get across. Like, there's no reason for anybody to suffer going through menopause or perimenopause. Like, in this day and age, like in the year of our Lord 2025, there's absolutely no need at all. Now, unless you're dealing with particularly poorly educated healthcare professionals. But in the broader scheme of things, there's no need for it at all. So the way forward is to bring it out of the shadows and to have these conversations, and just to kind of demystify it, and I think, like, maybe because I've been working in pelvic health for so long, like, it's easier maybe to bring up taboo topics, like periods or bladder or bowel or sexual health or pelvic pain. But honestly, by normalizing the conversation, and I see this at both ends of the reproductive life, because absolutely with menopause and, keeping women active and masters athletes, but also let's start that process earlier with teaching girls about menstrual health and, understanding things like REDS, or if they're having issues with bladder or bowel, or period pain or endometriosis. Let's just normalize that conversation, because, we are talking about 51% of people on the planet. And if you live long enough, you're going to be going through menopause. So it's not a big secret. It shouldn't be a big secret. It's a basic fact of female life. You're going to have about 400 periods, between, let's say, the ages of 12 and 52. So the sooner we kind of get to grips with the reality of that and the practicality of it, the better for everybody. The less likely we are to stab all of you.
Interesting when you say that, because literally it's like you've triggered this. A common response then I hear. So I am actually, I'm got myself into a comfortable zone now. It's probably come with age, confidence, the coaching side of things, I think, to specifically always ask about stuff, menstrual cycles, hormones. So for me, I'm the converted and feel quite comfortable with it. It's just more kind of like, the change was just a piss take on, like, what people call it. And that exactly what you just said, to demystify it, it shouldn't be this kind of thing that's parked over in a drawer. But what I'm really interested in what you just said there now, because a common response I'll say to people, so I'll ask them what their medication is, which is a nice way in sometimes, because and they'll say, I'm on HRT. And my instant one is, does it work?
Yeah. Now,
there's an interesting response on that. And the most common one I often hear is exactly as that, well, I no longer want to kill people. All right. And so I'm like going,
it's a good outcome.
Like that. I said, and it's we laugh, but again, it's completely linked to that side of things. So I wanted to ask you, regards to, like, empathy around these conversations.
Yeah.
Where should maybe people listening to this kind of go with leaning into that, or where is the empathy with what's the word? Yeah. Like, around conversations like this, someone says does that do anything for you? Does that change your opinion, where conversations go, for example?
Yeah, I think, like, if you're going to be working with adult female human beings, where it's not just empathy. I'd like educated empathy. I'd like informed empathy to be kind of the cornerstone that you have these conversations on, because people think menopause and they might think, hot flushes, night sweats, those are, and a bit of rage thrown in as well. But, like, there are some fairly serious health issues that we need to consider as well. Things like bone health. 1 in 2 women will sustain a fracture, after the age of 60, and 20% of them will be dead within the first 12 months after that. The leading cause of death for women is heart disease. And it's poorly recognized in women, it's poorly treated in women, and it's often not diagnosed until after they've died from it, because we lose the cardioprotective effects of estrogen after menopause. For every 3 people that are affected by dementia, 2 of them will be women. And again, because we're losing some of the cognitive protective effects of estrogen after menopause as well. So it is a serious issue, but, like, there's about 35 recognized signs and symptoms of menopause at this point. And if we don't look beyond the hot flushes, the night sweats, the aggravation, we're missing a huge opportunity to educate women about how to take charge of their health, whether or not they choose to use MHT, which is the current term for it, because we're not replacing hormones. It's menopausal hormone therapy is the current accepted term for that. And also we have to then, of course I'm going to talk about pelvic health, because we have research showing that for 1 in 2 women, pelvic health concerns are a barrier to exercise. And so if we know that pelvic health concerns go fairly exponentially through the roof at around peri and into post-menopause, when we start to lose those, again, protective effects of estrogen, if we're not screening for that, if we're not able to have a conversation, even if you're not a pelvic health physio, to ask the questions about these things. If you're seeing somebody for back pain, we've known for a long time that for women with back pain, they're more likely to have pelvic floor dysfunction, constipation, and some breathing dysfunction. And a lot of that can be tied to central drivers as well. But even if we, again, sticking with the back pain, let's say in women, the Oswestry back pain questionnaire used to have questions about sexual health in there as well, but they were taken out because physios were getting too embarrassed about it. And so, I think we have to kind of just be able to be grown-ups in maybe having these conversations. Like, it is back in the primordial mists of time when I graduated from UCD with my physio degree in hand. But at that point, all ACLs were alike, all rotator cuffs were alike, all glute med tendinopathies were, they probably hadn't even invented glute med tendinopathies at that point. But now we know, for example, I've rattled off a couple of stats about brains and hearts and bones at menopause, but even before menopause, we know that ACL injuries affect 7 times as many female athletes as male. We know that estrogen has about 300 different functions in the female body, and it really has a strong effect on the musculoskeletal system, as well as, all of the psychosocial drivers. Estrogen is very much a people-pleasing hormone as well. And that's part of the reason why I think a lot of women, when estrogen levels they roller coaster a little bit at perimenopause, and then they drop off at menopause. You just become a lot less concerned about what other people think when you reduce your endogenous production of estrogen. But people don't recognize that there is a whole musculoskeletal syndrome of menopause. There's genitourinary syndrome of menopause. There's cardiovascular, there's cognitive, there's metabolic syndrome of menopause. We know things like irritable bowel syndrome go up at menopause as well. So menopause will literally affect every single body system that we have. You're not sleeping. You're not changing how you're eating or exercise, but all of a sudden you've got an extra 10 kilograms going on out of nowhere. Your brain isn't working properly, possibly because you're not sleeping, but also because of life. That's classically the age when women are stuck between kids and parents and relationships and work. So there's a lot going on, and there's still a lot of social and cultural pressures on women that, to be honest, men probably don't face the same way in terms of maintaining looks and appearing young. So there's an awful lot going on. It truly is a biopsychosocial issue. But with what we now know about menopausal hormone therapy, that it's suitable and it's safe for just about everybody, even if in some circumstances you've even had breast cancer. But there is a difference between systemic hormone therapy and local vaginal hormone therapy, which we would use for things like bladder or sexual pain, or just dryness or any chafing that's going on down there. So there's a couple of different types of hormone therapy to consider, whether we're going oral or transdermal or an IUD. Do we add in some testosterone into the mix here as well? So it's a nuanced conversation that unfortunately was thrown under the bus about 25 years ago with the WHI report, which really is still haunting us to this day. And I have to kind of give a shout out to the Irish government, because now we have free MHT here. We free contraceptives up until the age of 35, and then we free hormone therapy after the age of 45. So between 35 and 45, you have to find your own way. But I think just acknowledging that it's responsible for women dropping out of the workforce, for women suffering unnecessarily. And it all comes back to educating women about the options that are available to them and just reminding them they don't have to put up with not feeling great. They don't have to put up with feeling awful. There's so much out there. It's not the be all end all. You can't just take your hormone therapy and not do the work as well. And exercise is probably the closest thing we have to a magic bullet. Like we know, for example, that 12 weeks of strength training can reduce your hot flushes by about 44% without any hormone therapy. So, it's lifestyle in the broadest sense of the word, but also, as I said, it is 2025. Like we're not going to be Luddites about it. If it's the right choice for you and you're making an informed decision, it can absolutely be a game changer. But it's a nuanced thing. It's not one size fits all. It's like if you go into Penneys and you buy a pair of elasticated sweatpants, yeah, they're going to fit everybody, but they're not going to look great on anybody. You go to Versace, you have something tailored for you, you're going to look and you're going to feel fabulous. And hormone therapy should be a little bit like that. There are so many different formulations out there that if one particular strategy doesn't agree with you or doesn't do what it says in the tin, you need to go back and you need to have an informed provider who's going to be able to give you that level. Okay, so we know that this didn't work. We know you're still having these symptoms. Let's try this instead.
Bang. There you go. Whew. So I got that Strandhill dump of wave of information, which is phenomenal. And I'm sure anyone listening to that, there's going to be some good stuff. I think what describes there is obviously just some really useful stats in that. The great one, the hot flushes one, I didn't know that. That's really cool. The first word that comes to mind, and I can imagine I definitely see this, is overwhelm from even what you just said. So all that stuff is really great. And I know you're just, you're getting out there. But I think that's what's faced. The common things I see when I'm interviewing females around that age group is that all those things you said, so the pressures, the social pressures of what they look like, they need to they need to be doing strength training. They need to be sleeping all these hours. They need to also be, not all, but certainly have children of an age that requires a lot of attention still. There's pressure that they need to be working still or have that pressure financially, and to also not look like that's causing them any trouble. And so even like all the fact that you said there's so much great stuff out there, we've now got much better evidence. The people now going through it are in a much better position than if you were 20 years ago when all that stuff came out.
Oh yeah.
And I want to explore that in another question as well, but it's kind of overwhelmed. And then all I know is that female relations to me are just peppered now. And I think the common thing is that they're like, I don't know what to fucking do. Yeah. Or access for some women is like, oh yeah, my GP is, but now I know I'm here in the UK, so it's slightly different, but the access, some GPs are absolutely banging. Other GPs are a bit reluctant or probably not specialist in that. And I think what someone listening to this who's just maybe not a therapist, they're just a patient, or because I think therapists would benefit from it as well. It's like, how do you navigate that? So I know it's a big question.
It's like, not to be a one-trick pony here, but like it all comes down to educating girls and women about how their bodies work. Like we know more about how our phones work than we do about how our bodies work. Like how to do a filter on Instagram versus can you name me the 35 signs and symptoms of perimenopause? Because for many women, it starts maybe with anxiety or depression. And so a lot of women will go to their healthcare provider, and if they are not, I'm going to just kind of go off on a slight tangent here. If, as they are not, as you said, a specialist, first of all, I think that's outrageous because 51% of the population are female and are going to be going through this. It's not a specialist. It's not a niche topic, you know?
Yeah.
So every GP should have the basics, at least, about menopause. But I digress.
Yeah.
It's about teaching women that feeling awful shouldn't be their norm. And it's about understanding, like menopause was never mentioned to me in school, you know, doing biology or anything like that. We did human reproduction, and a lot of it was kind of just centered on how how to get pregnant, how not to get pregnant, you know, moving on. But I don't think we give girls and women enough education and good information about how their bodies work. And the dark side of it is now is that menopause is becoming big business. If you go on Instagram or TikTok or any other social platform, there are lots of people wanting to sell you lots of things in the name of better menopausal health. And honestly, menopausal health doesn't have to be complicated. You want to eat more plants, you want to lift more weights, you want to cut out the booze. Alcohol is not the friend of anybody going through menopause. And you want to really focus on getting your sleep, because that's all going to help get your head right. But again, knowing when your last menstrual period was, and being able to track your menstrual cycle from 1 month to the next. Like the American College of Obs and Gynae call periods the 5th vital sign, because that's how important they are in terms of giving us information about how female athletes are doing from a recovery or training or performance perspective. But certainly when we're going into perimenopause, one of the first recognized signs of perimenopause is the periods start getting really irregular. They're disappearing for a couple of months at a time, or they're coming closer together, they're lasting much longer, or they're getting much heavier and much crampier. And that can throw everything out the window in terms of physical and mental health. So it's no matter what somebody is coming in to see you for, that will be a key question. But if you're on hormonal contraception, you don't have that 5th vital sign to give you that information. So then we look at your age. We think, well, if you're over 45, we don't do blood work for menopause because it's assumed that you're in that zone. Between the ages of 40 and 45, that would be regarded as early menopause. But women can have what's now called premature ovarian insufficiency. So I've seen, girls 17, 22 going through premature ovarian insufficiency. They're going into menopause at that age. And they, from a bone health perspective particularly, or let's say they're having, they've had a hysterectomy, or they've had cancer treatment that's affected their fertility, that's affected ovarian function. These women particularly need protection for their bone health, because that could lead to some serious bother down the line if we don't optimize bone health. Certainly in the 20s, but really up until the age of 40, I think there's a little bit of wiggle room in terms of how much bone we can actually build. It does taper off once we lose estrogen at menopause, but we still know we can maintain or even slightly improve, again, by bringing in the strength training. So I would just love to see more of, like, when was the last time? Did you do trigonometry in school?
Yeah.
Yeah. When was the last time you spent a lot of time thinking about an isosceles triangle?
Yeah, exactly.
Like, seriously, thank you, Archimedes and Pythagoras, but seriously, like, in terms of just basic life skills, understanding what's happening to your body at different ages and stages, I think, and learning, of course, like learning how to cook healthy food would be great as well, but I don't want to reach for the stars. But just learning the basics of how your body works and what it needs at different ages and stages as we go through life, I think would be a really useful skill set to have, particularly, as a teenage girl coming through, but also, for teenage boys too, and to recognize what might be happening with female relatives, because it was talked about in such hushed terms for saying, oh, don't go near her, she's going through the change, And it was just, when you start hearing these weird euphemisms for it.
That's why.
No, I know. No more of that. Don't make me unleash my menopausal rage upon you. Heads have rolled for less, okay?
I'm sure.
Yeah. But for me, that's what it all comes down to. And for many women, it is about being an informed consumer when you are going to see your doctor. And that's why I think kind of tracking your symptoms over, let's say, 2 to 3 months. So you can go into your doctor with data and you can say, well, look, this is what I've been feeling. This is my last period. Here's what's been happening. I'd like to have a conversation with you about strategies to help me navigate. It's not a disease. It's not a pathology. It's a normal life stage. So we don't want to over medicalize it. But at the same time, like if I develop type 2 diabetes, I'm going to be looking for some insulin. If my thyroid packs it in, I'm going to be looking for some support there as well. So it's not an admission of failure to look for menopausal hormone therapy and do the lifestyle strategies as well. Like
Can
that's
I?
the
Yes. Yeah. Sorry. Yeah. No.
yeah.
It's just because something jumped in my head, and I don't want to forget it. And hopefully it's an okay question to ask. It's the so sometimes again I'm just thinking of answers I get back. So some of the answers, like I'm saying, I don't want to kill people, or or some are like, it's amazing. You know, they're
Yeah.
like, this is great. It's don't take it off me. I get the other answer is, I don't want to kill people, which is kind of in the middle. And then you get people a bit like, meh, it's okay. So when it comes to just a real ignorant question on, because of all the benefits of it for the things you said around the cognitive and the cardiovascular health, like, I think those women struggle a little bit because they're like going, they haven't had that kind of like where their mate's gone, oh, I feel amazing on it, or this has really helped a certain symptom.
Yeah.
Where do you stand with, you know, I don't know if there's a reassurance there. Is there a conversation to be had then?
Yeah, there's definitely a conversation to be had. I would say, first of all, if you've been having a lot of significant, and like, just to be like super clear, I'm not a prescriber of
Yeah.
menopausal
Of
hormone
course.
therapy, you
Of
know.
course, yeah.
I'm very interested in looking at it from a lifestyle perspective. So if you're not sleeping, if you're dealing with anxiety or depression, if you have developed out of nowhere significant hip pain or shoulder pain, and things like gluteal tendinopathy affect 1 in 4 women in their 50s, and it's often misdiagnosed as hip osteoarthritis. If your tendons aren't happy with you, if you're tired, if your head's not right, it's very hard to say, well, you just need to go eat a bit of broccoli and lift a few weights and you'll be grand. You know?
Yeah.
It just doesn't work like that. But if somebody has tried it and it hasn't worked for them, it's like, okay, but it's not like one and done. There are so many variations within that. So you need to try a different formulation. Like for some women, taking their progesterone orally doesn't agree with them. So they might benefit from having an IUD instead. We now know, like, the gold standard generally is regarded as transdermal estrogen, so either a patch or the gel, and then oral progesterone. But there's loads of different variations within that. You know, you could have your systemic estrogen delivered through a pessary that you insert, you know, internally, and just have it delivered that way. So I would say, just because someone says they've tried it and it didn't work for them, they're still having all these menopausal symptoms. I want to know, what did you try? And also, are you doing the work? You know, are you still having your coffees to get going in the morning, your gin and tonic to unwind at night? Are, you know, what are you eating? How are you moving your body? What are you doing to manage your stress? Like, what are you doing for fun? I think is one of the most important questions we can ask. And it sometimes will take people a worryingly long time to answer that question, which is always a red flag for me. So I want to know, like, I want to know about your life.
Can I? Yeah, that's a good. Why is it a red? So that what you just said there is common for me to see.
Yeah.
So when you say a red flag, what do you mean by a red flag? When they say when it takes them a long time to find what they do for fun.
Yeah, like, where is the joy? Like, what is the point? You know, are you just surviving your life? You know, because we talked before we started recording about a colleague who's had a very significant life-altering injury. And it just kind of puts things into perspective. You know, nothing is promised. And like, are you just going to keep trudging through in misery? Or what can we do to help you actually regain the joy, regain a bit of fun? What did you used to do if you can't think of anything that you're doing for fun right now, what did you used to do for fun? Like, what makes you happy? What made you happy in the past? And what's stopping you from bringing some of that into your life now? And if someone can't answer that, like, I'm going to be bringing out things like, you know, the DAS to screen for depression and anxiety. I'm not saying that, you know, broccoli and lifting weights will cure every ill. But we do actually know that strength training has been shown to be almost as effective as talk therapy and medication for mental health. We know that the gut-brain axis it's an information superhighway from one to the other. So it's not about just throwing medication at something, whether it's hormone therapy or antidepressants. It is about looking at the whole person and their story and their goals and their life into, how can we make this better? You know, how can we work together to give you a path back to joy and back to enjoying your life again?
Yeah, really nice. You deal with athletes, obviously. You advise for FIFA, don't you?
Mm-hmm.
What's the crack with masters athletes then? The conversations there. Anything that you'd like to kind of would bring up around that, or what? Like, you know, if you are, I see masters athletes. They're maybe not professional, but they're doing ultramarathon running.
Yeah.
They're doing some impressive things.
Yeah.
It would be considered athletes with the amount of training they do, but they've run a normal life. What? Anything you'd like to say around kind of those types?
Tendons. Tendons love estrogen.
Yeah.
And tendons hate change. And like, it is the change, you know, that we're talking about here.
Yeah.
You know, for many high performance athletes, they may have postponed having their babies. And so potentially, if you have somebody who is, you know, technically a masters athlete, let's say, is over 35, you might have somebody who's both postnatal and perimenopausal at the same time. And we're now seeing that that can actually be a really high risk group for REDS, because the pressure to get your body back after baby is real, but particularly when your body is your business.
Yeah.
And to lose that baby weight and to get back into training and performing really quickly. So we have to be very careful about things like screening for REDS, about avoiding bone stress injuries, but also, you know, to talk about tendons, because if we're talking, a lot of runners, particularly, they don't like to do strength training because they're afraid it will bulk them up and they'll be too heavy. And I'm going, no, the strength training is what's going to keep you running for longer and for happier, you know, and get you back to performing at that high level again. Because that is what tendons need to be happy and healthy. There's been a couple of interesting studies looking at the effects of hormone therapy on tendons. Cowan et al. From 22 looked at adding in hormone therapy, estrogen particularly, for people with gluteal tendinopathy, plus exercise, plus education. And what she and the group found is that actually it doesn't even really matter so much what exercise strategy that you're using for it. Adding in hormones, adding in some estrogen will be effective, but only if your BMI is under 25. Because if your BMI is over 25, we assume that with that bit of extra of being in that overweight zone, you're in a higher state of inflammation, and the estrogen will not work as well in lowering your inflammatory load. Like, it's good stuff, but it's not magical superpowers. It has to work in the environment that you're giving it. And there's another research study in progress now at the minute looking at, because with that study, when they added in some topical estrogen, they just put it in a neutral site. They didn't actually put it on the painful site. And now they're actually looking at, say, with somebody with rotator cuff injuries, if you put it locally on the shoulder, does that actually make a difference versus putting it in the neutral zone that, you know, you're advised to when you're just adding it for normal people using it as hormone therapy?
So they reckon localized could be even more.
We're waiting to see. And
I wonder if
I just anecdotally, I was doing some rage weeding back in May, and I absolutely developed a stinking tennis elbow. Oh no, it's a thing. I developed a stinking tennis elbow afterwards, and I was doing all the things that they said I was supposed to do for tendinopathy, but then I started putting the estrogen gel, and this is just N=1, but that was what actually turned the corner for me. I started putting it on the elbow, as well as continuing to do all the things, the isometrics and all the other jazz. It took its time to settle down, but it was literally going nowhere until I started doing that. So I'm really excited to see if we can get some concrete evidence to say that actually, doing it locally would be more effective.
Because then I remember Joe Gibson was saying about there's some stuff on frozen shoulder as well.
Yeah.
And I wonder, would that be of a similar ilk?
Absolutely, because we know that for women who do not use any sort of MHT, there's something like 99% more likely to develop a rotator cuff tendinopathy. So, you know, O'Sullivan talks about, you know, the 50-year-old shoulder. We've got, you know, Alison Grimaldi talking about this, you know, and the LEAP trial from Mawler a couple of years ago, talking about gluteal tendinopathy. But this is all happening to perimenopausal women. You know, it's probably not plantar fasciitis. It's probably a posterior tibial tendinopathy. And are we aware of the effects that these hormonal changes will have on tendons, on joints, and even if you do end up, let's say, needing a joint replacement, if you use hormone therapy, you are 40 to 60% less likely to need a joint replacement revision if you're using hormone therapy compared to if you're not.
So that's really useful stuff. When it comes to then, right, let's say, because you want to signpost correctly, don't you? Like clearly there's loads of benefits here. And I think anyone who hasn't been under a rock understands the benefits of it, especially in the therapy world. So when it comes to people coming into me, so I'll have I put up the recovery systems. That's how I do it. It's like, sleep, nutrition, stress, anxiety, immune system, hormones, load, right? And I just get them to, I say to them, use a color code of a traffic light. Green, going well, no big issues. Amber, red, not good here. And I get them to have a look at that. And obviously, like where is along with the overwhelm, and if women are coming in and they're in that you're suspicious of this, and they haven't brought it up, they don't think they're perimenopausal.
Yeah.
But they're in that zone and they're coming in with things like this. They're at shoulders and tendinopathies and stuff like that. Where do you stand with regards to, you're like going, right, I could treat this with load management, like you just said, right, your elbow.
Yeah.
And then are you pissing in the wind a little bit? Or where is the line of going, well, maybe do you want to check, how do I have a conversation with somebody who might be like, don't really want to talk about this. I don't think this is what we want. This isn't to do with I don't believe this is to do with my thing, right?
Right.
Do you know what I mean? So how do I approach this conversation when sometimes maybe, it would be worth going to your GP and maybe having a consideration, or how do you approach that? Do you know what I mean?
Yeah. So I would say like two prongs to that. First of all, ask them, like, so have you heard, talk to me about your menstrual patterns. How are things going in terms of your menstrual health? Are your periods regular? Have they changed at all over the past 6 months? Because they may not join the dots from menstrual changes to tendon problems.
Yeah.
And so then the onus is on us to educate, actually, that there is this link between what's happening hormonally and what's happening musculoskeletally as well. And then, of course, what's happening hormonally is going to affect your insulin resistance. It's going to affect your sleep. It's going to affect all of those things that we know kind of add into the mix with unhappy tendons as well. And just, ask them, have they got a GP that they can talk to about this? That's the difficulty. Have they got a good GP who is well versed in this? Ideally somebody, in the UK who's maybe a member of the British Menopause Society would be kind of, I would say, a good step towards finding somebody who should be able to have these conversations. But all physios know and love to cite the paper about it taking 17 years for research to trickle down into clinical practice. The GP may not be aware of the musculoskeletal syndrome of menopause. Like that paper, literally, there's been a couple of other papers over the past, let's say, 5 or 6 years. But I'd say that's probably the seminal paper on it, and it came out in 24. So unless they are very clued in to A, musculoskeletal health, and B, menopausal health, the musculoskeletal symptoms of menopause might not be on their radar. So they might look at the patient as if she has two heads when she goes. So if you are going to send somebody to the GP, maybe send a letter to the GP first and prime them, and send a link to the article as well. So it's on their radar, It's you can only ask the questions, if people want to know about these things. So ask her, again, just ask her about her menstrual health and educate her as to why this might be a factor. And then if she's interested in learning more about it, the door is open. And if not, because, and I would say particularly for athletes, whether high performance or weekend warriors, there is still a negative association with menopause and aging. And that can be quite confrontational for a lot of women to face, that this is something that they're facing into because they think that's an old person issue. And they're not interested in talking about bone health or heart health or brain health because that's an old person issue. So if you can make it a safe space to talk to about how it's actually currently affecting your tendons and how we need to stop this, turn this around, and then get you into like a preventative program of ideally strength training and anti-inflammatory lifestyle to preserve your tendons and keep you enjoying the physical activity and exercise that you've been doing, that's absolutely the goal. We never want to tell anybody that to stop exercising.
Yeah, you went and answered another great question there about that other group that I'll see is nearly like a denial group, or a group that were kind of like nearly a bit past this. And now I don't want to use the word bitter, but you know what I mean? I could imagine I would be. I'll just say if I kind of went, fucking hell, I could have been on that, and I could have gone through, and I didn't have to go through that hell.
Yeah.
So then I've got two choices here. I can either be really bitter about it, which I could easily understand why people would want to do that. You know,
and I mean, an entire generation was robbed of access to hormone therapy.
Yeah, this is it. Like, that's what I'm talking about.
Yeah.
Like, you know, and how people will, you know, that's, you know, there's nothing worse than that, isn't there? Like, you know, I could have.
Yeah, but
okay,
that's where throwing in the knowledge bombs about, you know, 12 weeks of strength training, dropping your hot flushes by 44%. That's where we talk about things like the Lift More trial, where heavy lifting not only halted the progression of osteoporosis, the people actually grew a little bit taller that were doing this program. There were no adverse events. We know that exercise is super effective for your mental health as well. It's good for your cognitive function. It's the closest thing we have to a magic pill for heart health. We know that a primarily plant-based, you know, healthy, whole food, Mediterranean style diet that is focused very much on your veg, your oily fish, and maybe meat a couple of times a week, and omit the alcohol, that can turn around your inflammaging. Is a term that I really like for this.
Yeah, it's good, yeah.
Because that's what's actually speeding up the process. So just because you haven't had access to hormone therapy doesn't mean that the doors are closed. It means that, yeah, we can still do so much to turn things around and get you back again to enjoying your life again. That's just one avenue. And particularly if pelvic health is a barrier to exercise, there's no time limit on vaginal estrogen, because GSM is progressive. Vaginal estrogen is just absorbed locally. It's very safe, again, even if you've had breast cancer. And, you know, the old guidelines for systemic hormone therapy was, you know, you should ideally start within 10 years of your final menstrual period or under the age of 60. We're starting to see a little bit of wiggle room creeping into that, in that we take more of a bespoke approach to the person in front of us, looking at their risk profile, particularly their cardiovascular health, because that's one of the main reasons that we have those kind of cutoffs, those arbitrary cutoffs in place, because there's almost like a healthy cell theory that we want to give estrogen particularly to healthy tissues. We don't want to give it to diseased tissues, because estrogen is very much a hormone of growth.
Yeah.
And that's why we give progesterone with it. Like, estrogen is like putting fertilizer on your lawn, and progesterone is like the lawnmower to keep it in check. So it is about getting kind of like a balanced approach to it, particularly if you still have your uterus, if you haven't had a hysterectomy. We definitely need that to protect against things like endometrial cancer. But it is about taking a balanced approach, again, across the spectrum of all, you know, control your controllables, basically, is where we're going.
Yeah, useful, really, really cool. Yeah, Jesus, you're like a bloody a machine gun of information. I'm going absorb now. Absorb like estrogen. That's all I kept thinking. I'm like going, I think I need estrogen.
I mean, it's worth a shot, you know.
I definitely don't. Well, speaking of which, just to make it, because, you know, that all that's, I can't imagine anyone not thinking, you know, great useful information. I always like a little bit of fun and a little bit of, you know, has there been anything, and I say funny, but like, I don't want to make fun of something like this either, but at the same time, is there been anything in your career or that's a funny story with regards to this that then changed your approach as a therapist or a patient scenario or anything like that off the top yet?
Well, it's just, you know, it's kind of when you're sitting down with somebody and they're coming in with all of these random, like they might have come in with one problem, but on deeper inspection, they're actually ticking off all the list, and then you ask them about their periods, and then you can kind of see the clouds parting and going, oh, so this is perimenopause. And it's like, you know, because they never put these pieces, you know, they came in, maybe they were coming in because they were having a bit of bladder leakage and they were having pain with sex. And then we kind of, we started just, building out the picture of what was actually going on in their lives. And yeah, they started having a bit of anxiety driving, and they just noticed they were a lot less tolerant of people putting dirty dishes beside the dishwasher and not in the dishwasher. And and there were a couple of examples like that. And they said, so talk to me about your periods. And she was kind of thinking, oh, actually, it has been a while. It has been a while. And okay. Now, it doesn't mean that we are now giving a free pass for putting dishes beside the dishwasher and rather than in the dishwasher.
That's all I heard.
Yeah, I know. You're not a man by any chance, are you? just checking. It's something. Yeah, it's something about that Y chromosome. Anyway, it just means that we have to just be aware of how menopause, how estrogen in particular, but menopause in general, will literally affect every facet of your life. But it's not the enemy. It's like, for most women, we've been riding the estrogen dragon for many, many years, and it's not for the faint of heart. But it's just about knowing your body. And that's why I'm a big fan of teaching young girls to track their cycles. And we don't recommend phase-based training anymore, because it's not one size fits all. But it is all about N equals 1. When I'm teaching, like when I'm talking to a group of young girls or young female athletes, it's about, well, here's the research, but I want to show you how to do your me search. And really getting to know yourself. Like, if you know that you are going to be like really tired when you've got your period, what's your training going to look like then? Or if you're prone to a little bit of constipation, let's say in the luteal phase, what are some simple strategies we can do for that? And it's just about like getting really, really tuned into yourself and how your hormones and your, how they're affecting your life and how your life is affecting your hormones as well. Because if you're stressed, you're more likely to miss a cycle. If you're traveling, if you're not eating maybe as well or as often as you should be doing, the period is the 5th vital sign. And so the information is there if you know where to look for it. So you have to be able to do a little bit of detective work. But again, it's just about getting really tuned into yourself and keeping track of the data.
Yeah. Yeah, no, really good. I think what I want to finish up, and I didn't ask you, and I don't want to go through a podcast where I didn't ask this question. I nearly forgot with somebody else as well, and I love this question because it's my favorite question, which is the music question.
Yeah.
So if you like, I suppose the question is just, how would you represent yourself with music? What music, song, band, or what does music make you as a coach, therapist, or a person?
Yeah, my song when I'm trying to like get ready to do anything or kind of get out of my head, get ready, Nina Simone, I'm feeling good.
I'm just thinking, this sounds really mad, but that's that was sang at my sister-in-law sang at my wedding. That
no way.
Yeah.
Very good.
It's a great song. You can't beat Nina Simone.
You're not going, if you've got Nina Simone going in your head, if that's the soundtrack in your head, nobody's going to mess with you. Guaranteed. That is the sign of a well-regulated nervous system. You're safe.
Brilliant. And I suppose just when it comes to, we talked about, I think we'll finish on this one. It's just educating kids. Like, I've got young kids, right? So they're 9, two twins are 9 and I have an 11-year-old. And we've kind of been trying to drip feed in, reactions or emotional states or changes in that kind of stuff, or just to explain kind of behavior. So we're definitely an Irish Italian. Well, she's not Italian, but she's got part French in there. So we're kind of very much explosive, and then we'll always talk about it afterwards. You know what I mean? This is what we did. What happens. That's our approach. Which. So I'd be interested to what's your thoughts on like kids and about that, and maybe some of the language around it, so you don't end up using old shit language that you can remember from when you were, you know what I mean?
Yeah.
I asked Angela Jackson about this, about pediatrics, and she came out with some, belters, and I'm always like, oh yeah, that's so much better than what I was saying. So have you any kind of maybe things or age groups appropriate kind of conversations?
I think just use the proper anatomical terms for body parts. Like,
okay, sure, yeah.
it's so important, and it's so important because we actually have research showing that kids who've been taught the proper anatomical names are much more likely to recognize and alert grown-ups if there's any sort of abusive situation going on. Whereas children who are taught, like funny names and hoo-ha and, front, bottom and things like that, they are much less likely to report any sort of abuse. But if you teach a young girl, even the difference between a vulva and a vagina, and just normalize the use of body parts, or proper names for body parts, like that's they'll already be so far ahead of the crowd. And that it's a great platform then for building on their education at appropriate ages as they go through life.
Same for boys as well, yeah.
I mean, you would never.
No, as in the research you said.
For all, but I mean, you would never call a boy's penis his testicles or vice versa, or his scrotum. We tend to use the names maybe a little bit more easily for boys, but just teach everybody the proper names for their body parts, so it's as innocuous to them as an elbow or a knee.
Yeah, no, I definitely think that. And when it comes to talking about that but specifically for menopause,
do
you think do you have any insights into that one, or because again, just so because some women, I suppose kids would be coming into teenage years, which will be their own hormonal changes.
Yeah.
So if there's
good luck with that, by the way.
Yeah. So basically, help me out, will you? Just come over to my gaff soon.
Absolutely, speed dial.
But even around girls understand, because I guess girls are going to be going through their starting periods, and then their mother or whoever, or their relations or aunties, whatever, will be going through this. And I don't know, maybe I'm out of, but you'd often had that kind of feeling, like nearly as a bloke looking in, sometimes young girls were nearly like, oh, mom, it's nearly slagging off their mum. Do you know what I mean? Like, it was kind of weird, like female on female kind of negativity. Do you know what I mean?
Well, I mean, like it can be an interesting time, like particularly as girls are starting their periods, because it can take a year or two really for the periods, to become ovulatory periods. So for a lot of time, you've got, for the first year or year and a half, you've got some unopposed estrogen going on there. And if somebody is perimenopausal in the same house and they're going through roller coastering initially in the early perimenopause into declining estrogen, it can be a fraught situation. I would say just make sure you have a lot of chocolate in the house.
No problem.
Plenty of hot water bottles. Bring home some TENS machines from work. But again, like, I cannot overstate how important nutrition and exercise are for hormonal health at both ends and all the way through the middle of that hormonal spectrum. So a good, again, making sure the omega-3s are in there, the oily fish, plenty of fruit and veg, sleep, again, tricky, but and exercise, because we do have a huge problem at the moment in Ireland, in the UK, in the US, in the Western world, getting girls into sport, but keeping them in sport and physical activity. And it's so beneficial in terms of menstrual health. We've already talked about its benefits for menopausal health. And it's just about getting those core foundational pieces in place as well. Explaining to her what's happening with the menstrual cycle. And again, like if she's tracking, she knows, well, look, I know I'm going to be tired. I know I'm going to be a little bit out of sorts. But if everybody knows that, we can go a little bit, easy around here.
Yeah.
And it's about just creating a safe space to have these conversations about the reality of our anatomy and physiology.
Yeah, cool.
Because, like, all I will say is, for women, we're on kind of like this 28 to 35 day cycle. Men are simpler creatures. They're on a 24-hour cycle. So this is kind of, this is next level stuff. So I'm saying this now to prepare you. Just, be calm, avoid direct eye contact, and just, a shed in the garden, I would say, could also be a happy space for you, with a lock on the door.
Brilliant. That you've answered a question without asking a question, so that's brilliant. Michelle, that's amazing. You're like they're really, really useful, and all of that is like, I'll be listening back to this because it was some great stuff, and I think people listening to who I know will definitely be really appreciative of it as well, because it's such a common thing, like patience as well. It's It's really good. And I won't take any more time. Anything else you'd like to say before you go? Do you like? I don't normally do this, but I just thought one because I always forget. But do you?
Are you going through the menopause?
This is what I'm saying. Maybe courses and stuff like that, because I know you do a lot of talk and stuff. But do you actually run courses?
Yeah, I do. So I have a heap of online courses. Again, aimed more at the healthcare professional, physios, osteopaths, body workers, massage therapists, fit pros. So, and then I do like some live in-person courses and conferences and things like that as well.
Cool. You got a website?
I do. I have a website, celebratemulierberty.com. So mulierberty, I always have to explain this. Mulierberty is an old English word, and it means the art and state of being a woman. So I think that should be celebrated. But all the info's on my Instagram, so that's probably the best place to keep track of what I'm up to.
Sand, you're the first person I'd like to do a big. Yeah, I know you must have impressed me, or I'm getting soft.
Thank you so much for having me on. I really enjoyed the conversation. Great questions.
Thank you very much. Thanks again.
Thanks for listening to Teacup. If you liked it, tell all your friends. If you didn't, well, maybe you'll like the next one. Go to procareeducation.com or Procare Education on Instagram for more information on courses and the Bamboo Project. And remember, always be sound and not a dickhead.